In fact, we are going to be ready to show you a similar case to my presentation regarding the chimney pathology. You probably see now a wire that is entering the aneurysm, the arch aneurysm. And now it's entering the ascending aorta. We can register that.
So, Ivo, that's a dissection or aneurysm of what are you treating?
It's a typical saccular aneurysm of the aortic arch. But in fact, my colleagues are ready to present for you the case.
Okay, that's relieving. Thank you so much. We are waiting for the presentation.
Okay.
Hello, everybody. I'm Dr. Velchev. I'm going to present you today's case. It's a 72-year-old male with hypertension, smoker, first admission to the hospital. And our main reason to admit him was shortness of breath and new onset of hoarse voice, also chest pain at rest during the last month. He had a negative stress test a few months back. So with the medical documentation we had, we saw a dilated aortic arch, and we proceeded with the CT angiogram, which was remarkable for a huge aneurysm of the aortic arch. It was starting just after the left subclavian artery, and it was the reason for his hoarse voice. So we planned an intervention on him. Here you can see some of the dimensions of the aortic arch. We had several treatment options. The first one was open surgery, total aortic replacement with reimplantation of the supraortic arteries. The other one was hybrid intervention with the branching of the supraortic arteries and implantation of stent graft. And the third one, the one we are going to do now, was total endovascular aortic arch repair. And the plan for today is total endovascular repair with chimneys, two chimneys from the supraortic vessels, one in the brachiocephalicus and one in the left common carotid artery. And something that I didn't note was the fact that the patient had truncus bovinum. After the chimneys, we're going to implant stent graft in the ascending aorta, and followed by coiling of the left subclavian artery. Now I think we can proceed with the procedure in the angio room.
Can you tell us what kind of stents you intend to use for chimney and what kind of stent graft you're using for the arch?
Yes, definitely. As I commented during my presentation about the chimney intervention for the arch pathology, we are intending to put Endurant. It's in fact a stent graft from Medtronic utilized. I'm changing now the subclavian sheet. Okay, you probably saw the subclavian sheet 12 French that is already on position. So this will be the route to put the Endurant graft 16 millimeter from the brachiocephalic trunk to the ascending aorta. And for the left carotid, in fact, we punctured, just a second, for the left carotid, you see, over there, we punctured the left carotid retrogradely, like I have shown. And we have already the 7 French sheet on place. You see the wire is going again, okay, and making a loop on the aortic valve. So we have two wires that are looped over the aortic valve, and they will, in fact, accommodate the two chimneys. In the left carotid will be a Bentley that will be 8 by 57, and most probably, in order to have enough distance, we are going to put telescoping one more, because there is no more than 57, in order to have good position into the proximal landing zone. Okay. And in fact, it would be good to enter the left ventricle in order to have good support for the aortic graft. What I'm trying to do now.
Sorry, I didn't get it. You're putting stent grafts in the arch artery, so you're putting a bare metal stent?
No, we are putting both stent grafts and endurance on both sides. We are putting stent grafts.
Okay.
We are putting stent grafts, and yeah, this is the idea, to provide the chimney for the brachiocephalic vessels for supplying the brain. Okay, I'm in the left ventricle now, and we are going to place here the Lunderquist that will support the aortic arch graft. Okay, so we are leaving the pigtail into the left ventricle until we are positioning the stent grafts for the ascending aorta to the brachiocephalic vessels. Now we are going to proceed with the endurance, 16 millimeter by 70 or by 90, in order to be deep enough into the ascending aorta, in order to provide good landing zone. And we have for angio we have placed the second femoral approach. In fact, we have 6 vascular accesses. 6 vascular accesses, both femoral, 1 carotid, the left one, 1 subclavian, the right one, and 1 radial, the left radial artery, because we are planning again to occlude the left subclavian artery, because it's originating from the aneurysm. And if not occluded, it will fill the aneurysm, and of course it's not a good idea.
We can show the puncture of the subclavian artery.
Yeah.
Using one trick.
You see, it's in fact, we placed, yeah, here is, you see, this is the sheet into the subclavian artery. In fact, we are used from the AAA treatment to put the grafts sheetless. So we, in fact, yeah, it's interesting maneuver. So we are using the pigtail from the right radial artery in order to, and the head of the pigtail is within the subclavian artery, and we are using the head of the pigtail as a target for puncture, in order to facilitate
in safety.
Yeah, for safety and easier way to puncture it. So we are changing now the sheet for the endograft. From the subclavian. Okay. Fortunately, the graft is quite flexible. Please keep the wire.
Yes.
Yeah, and this is the proof that the and the graft is quite flexible. Okay, not bad. Yes, okay. We can make an angio in order to take a look at the bifurcation of the subclavian and carotid in order to have the distal landing zone. Let's go for RAO, diastole caudal, right caudal, and we are going to inject the contrast in order to take a look from here or from
here is better, from the radial approach.
Okay, we are going to inject here. Ready?
Yes.
Go. Okay, we have to go
A little more deep.
quite deeper. Дай ми още caudal.
Да, caudalното ни е нужно, да, Саши.
We are going more caudal in order really to take a look at the bifurcation. Okay, ready?
Yes.
It's a little better, but still not enough.
That is the
More or less here.
Лявата листа.
Again?
Не,
No,
не,
no, no,
сега,
no, no, no.
сега.
Once again. Ready?
Yes.
Go, inject. I think
Now it's good.
probably yes. Probably 1 millimeter more, but we can do it. Yeah, it's
very good.
It's good. It's on the carine. In fact, the marker is sitting almost on the carine. So we are going to
Awesome.
proceed with the Bentley graft from the carotid. And after positioning the two stent grafts, we are going to proceed with the main, let's say, aortic one. So we are putting the 8/57. This is the longest from Bentley, the so-called big graft. Скопия?
Yes.
Okay.
Значи не е толкова ляво. Дай леко към фас. Yes.
Like that is probably not bad. We are going to make an angio. Okay, let's go. We are going to proceed now with the aortic graft. You probably saw that the Bentley graft is already there. The only detail that we have to decide to retract it a little within the carotid, because we need at least 2 centimeters of the graft to be within the carotid in order to provide good sealing of the flow. Okay. So you see the Wunderquist wire is in the left ventricle. You probably know this is the most supportive one of the all supportive wires. We are putting now a large sheet. It's 20 French?
Yes, 20 French.
It's a 20 French sheet, femoral sheet, on the Wunderquist. Валери, знам. Ще бъде за кратичко, спокойно. Айде, готов си. Браво, това беше. Okay, you see the patient is under conscious sedation.
Yeah, we're a little bit impressed by having a patient not under general anesthesia.
Yeah, it's under conscious
Yeah, I
sedation.
never did that, only with local, I must say.
Yeah, abundant local plus conscious sedation. And he's behaving very well, absolutely fantastic.
Okay. And the Lunderquist is stiffer than the Amplats?
Yes,
Stiff?
Lunderquist is, I would say, quite stiffer than the Amplats. So, we are going to proceed now with the aortic graft dedicated for the arch. And I would like to ask Ivo Andreev to look behind the screen of the IT guys. There is a box with the model. With the model of the pathology. This is crucial. You saw probably, because of the excellent wire, in fact, the endograft, the aortic endograft went quite smoothly. So we have to precise now the level of the Bentley. I think the aortic graft is not bad.
Somebody want to touch it? To take a closer look?
Yes. We
it's still
call
there.
that a jumping aortic arch. Not only elongated, also jumping.
Probably. We are going to check now, because the hemodynamics is perfect, everything is stable. We are going to check now temporary pacing from the left ventricle wire. In case it's successful, we will not put venous temporary pacemaker, but we are going to make rapid pacing during the aortic graft implantation through the wire of the left ventricle.
Perhaps we should explain that you need rapid pacing, otherwise the blood pressure will push up the endograft and then it's not placed exactly in the position you need it.
Exactly, this is great point. So this is the zone of the highest possible pressure. This is the ascending aorta. And because of that, we need quite a low pressure, around 40-60 of systole, in order to have stable implantation of the aortic graft.
Ivo, aren't you afraid that if you have this pressure that low, that the patient may be having, for example, a seizure during the rapid pacing?
Yeah, it's a good point. Good point. We didn't have to this date such a problem.
It depends on how long you intend to keep the pressure low.
In fact,
For seconds?
the aortic stent graft is not very long, so I can guess in probably 10 seconds we will open it. So it would be good. So let's try the pacemaker. Put on 120. SSO. 120. The capturing is not good, so probably we are going for a temporary pacemaker from the venous access. Okay, let's go for a, yeah. We are going to put just a femoral 5 French sheet in order to pace to temporarily pace the during the implantation.
And kissing. It's very important for the kissing. Pacing.
What Dr. Stankov is emphasizing is very important, not only during the implantation itself of the aortic graft, but also during the kissing maneuver, because it will be triple kissing, so balloon in both brachiocephalic vessels and within the aorta. So let's go with, I just put a venous sheet, femoral, and hopefully in several minutes, let's look behind, yeah, okay. Okay, that belongs to. Okay. We can try now.
Because we have now hard arrest.
Here, those 7 axes. 6 arterial and 1 venous.
Да нагласим другите.
Да.
Идеално хваща. Това е предсреден ритъм.
Спрях. We are still in the atrium, so the pacemaker is working, but they belong.
So it's a paradox. Puncturing carotid, no problem, but moving through the tricuspid looks more difficult.
Yeah, I think now we are better place.
Ровно. 120.
Давай на просто 40. Much better. 160.
160.
Fantastic.
Fantastic. Pace.
Pace off.
Face off.
So we are ready with the pace. We are ready with the aortic graft. I would like to make an angio.
Yes. Една идея да сташ. Не.
Още едно на едно искам. То не мога. Ресторк.
Заради клин долу.
There is a huge kink of the iliac artery on the right side, and because of that we have chosen the left for the main body of the aortic graft. Okay, we have now the pigtail on the aortic valve for angio. Okay, in order to take a look at the ascending aorta, ready?
Yes.
Go. Okay, we have to be a little further down, something like that. And also we have to position now the endurance from the brachiocephalic trunk and the chimney. No, it has to be more into the carotid because otherwise we don't have to.
Този ще го отворим, ще сложим другият.
Отзад.
Отпред. Това ще го отворим в картината.
Yeah, he has to go down far here because the aneurysm is in this elongated arch here.
Ще го отворим тук, това го спадаме и го насявам в него. Той не сега още по-добре. Дай ми инфлатор.
Okay, not bad. Etka. Okay, we are going to open the left carotid chimney now. It's quite deep into the carotid, so yeah, it will be quite stable. Okay, the left carotid chimney is open. So we can
Put now the next tent for the
probably,
carotid
I would like to try once again the position of the endurance collar.
But you told us that you will extend the left carotid artery chimney, so to bring it with a second endograft
Exactly.
closer to the ascending aorta.
Absolutely right. We are going to telescope it.
Yes.
Това много лесно го изпутва.
Дай 140 частота. Давай. Дай 16 на 26. Дай, дръж 120.
16 на проекция, Саша.
16 на 26.
16 на 26 проекция. 26,
Hold
ясно,
down.
hold down. 16. Така.
Давай. Not bad. Okay.
Okay.
Ready за 160.
It's necessary to put a second one stent from the left carotid artery.
Okay. Let's go.
Let's go with stent.
Do you have a certain reason why you have chosen the Bentley and not something else?
Yes. Price. And because the gore grafts are not available in Bulgaria.
Да, it's well.
We are not an interesting market for them.
And the Bentley, that's the B graft, you open that up to 8 millimeters or what?
In fact, we implanted the 8 one, and now we are going to telescope with a 10 millimeter in order to put the big into the small to have better sealing. Давай лява,
Лява, Саша.
за да виждаме как се движи това Бентли в другото Бентли.
Да.
Да не го избутам.
Great. Okay. Yes. Okay. Great.
Yeah, it's much better.
Yes. Back to the space. Не.
Okay. In the meantime, we have removed the pacemaker from the left ventricle. Sprig pace off.
Face off. Very fast.
Pace on. Стерилна летенка има. 120.
I have the impression that the aortic endograft moved a little bit back. Is that true or not?
You're absolutely right. And because of that, we are putting the pacemaker now gently on 120 to have some reduction before going for total opening.
Yes, going to the left. 30. It's great.
I think it's not bad.
Yes.
Probably we are going to need an injection.
In front of Panka.
Yes, definitely the chimney into the left carotid is there, and also the right one is just on the bifurcation, I mean the distal. So we are ready.
To start.
160.
Okay. 160. Now.
Now. I'm going to only free flow.
Не. Панки, ела ли да раздуеш балона, като се каже?
Бързо.
Раздуй балона.
10.
Okay. Pace off. You probably saw, we can repeat that. Okay.
За най-иската балон искам.
Какво да сяда?
За най-иската децибел.
Okay, good.
За ендуранта може да
We are going to put a 12 millimeter balloon now for the endurance graft in order to make the triple kissing.
За най-иската да деля Панкина. Удачи.
Ще го върши на място. Помагаме там да излизаме. Дизеле 12. So now we are going to interchange the endurance graft that was implanted sheetless in order to have smaller hole. We are going to put the 12-inch sheet and to position the 12 millimeter balloon.
Скопия. Окей.
Yeah.
Да. Може да един фатор. Имаме два.
So we are putting now the 12 millimeter balloon. Да. Много удачи. Okay, we are removing now the delivery system. Keeping the nose cone.
Окей.
Okay.
20 френчове до зелен.
Трябва да сложим на балончето.
Окей.
Ivo, what's the ACT that you want to have during this procedure?
In fact, we are using in the general case 5,000
Only
heparin.
5,000.
Yeah. And heparinized saline for flushing.
It's okay. Oh,
Okay.
the sheet. Remove. Little out. Okay.
It's perfect.
Perfect, yes.
Yeah.
Now we're going with
Now we are going to put the big femoral sheet instead of the aortic graft delivery system. Валерий, как си, момче? Браво, герой си ти. Супер. The patient is absolutely asymptomatic. So we can suppose he has good carotid flow. The dilators of the big sheet, sometimes it's quite difficult to be removed. Okay, so we are going to put a reliant balloon within the aortic graft. And the other two balloons are already on site. And we are going to be ready for rapid pacing, triple balloon kissing. After that, left subclavian occlusion, and final angio.
and close everything.
And close 7 holes.
For the left subclavian, you will use an Amplatzer plug, or what do you use for
No,
the...
for the left subclavian, in fact, we are planning to have prog light on both subclavian arteries and the carotid. I have read that stitch-based closure devices are better for the brachiocephalic vessels.
Push-pull.
Push-pull, we just at that moment we did the so-called push-pull in order to facilitate the balloon movement into antegrade. Let's go for 120 of the pacemaker in order to have some reduction. So we'll
Densitometric method.
So I think we can now clap the hands, yes. Very impressive result.
Do we lost the connection?
We don't hear anything. I don't know if they can hear us or not.
But it's very impressive how they can
Yes,
reconstruct the arch.
Yes, when I asked, I was not concerned with the excess sites, how they will close all the puncture sites, but how to occlude now the left subclavian artery, which is still connected with the aneurysm. So when you have cross flow from one side to the other, then you have also
But it looks
a
like
reversed flow in the subclavian, yes?
you think it's reverse? At least I have a feeling it's not, it's an antegrade flow.
Here yes, that I would like to see the endo again if the left subclavian is still contrasted. Because normally when you place the endograft across the orifice, yes, you place then you block the orifice of the left subclavian, but here this left subclavian is in the aneurysm sac.
Yeah,
so
the question is,
he wants to occlude also the left subclavian, and for that you can use an amplifier plug or other things. I don't know what they has available and what they will use. Amplifier plug is very fast. You have only to bring it in position. I see they are doing there something.
Yeah.
Yes? So I think yes, it looks like something like that. Yes. So.
What is the size of the catheter that you need to deliver the amplifier plug?
Yes, because it's a larger amplifier plug, yes, 6 or 8 French.
6 French will be enough?
Yes. There are different plug sizes also, yes. Depends on that. It's also the question what is available in Bulgaria, yes. I have no idea. Yeah, theoretically you can also coil it, but not with the coils we have seen for the brain arteries, but with these large coils which you can use there. Yes.
But the question is why they don't remove all the gear from the other arteries if everything is fine, so why keep the pigtails inside and everything?
So. No, the only point that I criticize is that they keep their hands too often in the X-ray exposure. So they have to check if they still have some hair on the back of the hand. You know? Yeah. Yes, radiation exposure should not be underestimated, yes, because when you look at the fluoro time with such a complex procedure, you have at the end a fluoro time about, 40 to 60 minutes, yes. And I can tell you, because I'm doing angios now for more than 40 years, for the ladies it's interesting. I have no hair anymore at the lower limb, because at former times, yes, the apron ended somewhere here, yes, so below that, the hairs are gone.
Колкото кажа, толкова.
By
Толкова.
scattered
Като
radiation.
кажем, достатъчно, достатъчно.
So therefore, and
Валери?
Dietrich,
Вървим добре, още мъничко остава.
Okay, so now we can hear you again. The
Okay.
connection was lost for a while.
Probably somebody unmuted us.
so you place now a coil there at the
Yeah.
RF, yes?
The origin of the subclavian artery.
Okay.
But I see that the flow is quite powerful.
Yes, we already discussed it, if you would use an amplatzer plug or coils.
Yeah, we have discussed as well to put an amplatzer. Okay.
Next coil.
Let's go next.
Не.
12.
Дай един по-голям. Дай 20 на 20.
Не трябва да има голям. 20. По-голямо от 12 имаме.
20 трябва да има.
Да, 20. Трябва да има 20, е огромен.
Още малко, Валери.
Yeah. Okay, super. So we are going to put now a really big coil. Stop. Айде още едно на едно.
Yes, and there are different coils, so there are some coils only metal, but other coils have also fine filaments to,
Yes, some bars.
to increase the thrombogenicity.
So those are detachable, I guess?
Yes, they are all. Yes, some are detachable, some you push through the catheter and then they jump out.
Идеално да се закачи там. Оставете. То ще изпълнява.
Yes, when Gutenberg invented printing in the 16th century, yes, he could not know that we now have 3D printing and can produce such a thing.
Още един такъв имаме.
Имам.
Ще почва да се формира.
Голям. Къде?
Хайде още едно на едно.
Още една
Направи се.
Да. Остави ми вторка.
So one part of the coil, or the coil is close to the aneurysm or already in the aneurysm sac, and the other one
Exactly.
is at the level of the origin of the vertebral artery and thyroid trunk.
Свободен пиктал имаш ли?
We see that
Starting
there's
to compact.
a new coil coming.
Yeah. It started to compact. Okay. So we are going to put one more. They're not nice. And most probably we are going to push finally down with a pigtail in order to be really on the orifice of the subclavian artery.
Няма кести този път.
Eva, do you foresee any problem removing the pigtails which are pinched along the graft in the brachial artery?
Tell me again.
Do you foresee some problems taking out the pigtail which is pinched in the truncus?
Yes. It's gel. Yes. No.
No.
In fact, we almost never had such problem. And we are going now with the pigtail
Още малко.
to дръжте тук.
Yes, you can also straighten it by another guide wire sometimes. Yes. You go in with the guide wire, and so it's a bit more stretched and not so tight curve.
Okay, we are proceeding now with the pigtail, pushing the coils.
Дълъг пиктел има ли? Къде?
Един дълъг пигтел ще направя. Дръж тук.
That was a guide wire. You brought in a guide wire now.
Super. Okay, we are going to utilize now a long pigtail in order to have longer than the guiding catheter. We are using a 6 French guiding catheter, right Judkins guiding catheter. And
Cada pace spre de.
ok, o stilică. Fixiramo udaccia.
He's trying to compact the coils with the
Yes, he
Petrov.
wanted to push the coils together.
Yeah.
Yeah. Here you see it. Yes. It works, but he will not be able to push it down to in the aneurysm sac itself, because there is already one coil there. And I would leave it as it is. Yes, because
I think it's most probably enough, but we can
Yes.
check. Okay,
yes, I
Valeria,
also recommend to check on it. I have the impression it's enough.
Yeah, Valerie, ne dišej, molite, ne dišej.
And it also needs some time until it occludes, yes? So there is a
It's
little
much
bit
better,
of...
you see.
Yes, there is a little bit of... but
Dišej mu now.
I think when you wait another 2 hours, it will be
Definitely,
occluded.
yeah,
Very poor
definitely,
flow.
it's much better.
I don't see the vertebral artery anymore here.
Yeah.
Okay, and they're on place, you see, they don't move distally,
Yes.
so it's fine. It's absolutely fine.
And it's no problem, even when it's not occluding. Yes, that can be done in a couple of weeks. Yes.
Oh, yes, yes.
Because-
What I wanted to comment you, that in fact we can make on a second step unplatzer occluder without any problem.
Yes.
Okay, so as I guess we are ready to close all the holes, and that's it.
To the remove from the sac.
So you have everywhere proglide systems.
Yeah.
And the endograft was
only the
20
femoral,
French, 20 French at the groin, or
no,
24
on the-
French?
No, yes, yes. Yeah, on the 20 French, we are going to close with Manta, the femoral, and we are going to close the carotid access and both subclavian by proglide.
And femoral with Angel.
And the femoral, the additional femoral with Angiosil. Okay.
Yes,
We are
so
going to proceed,
we now give you some applause again, so you know that
Great. Thank you so much.
We are very impressed, yes? It was really a very complex procedure.
Thank you so much once again. And we can, by the way, we can check the pressure. We can check the pressure.
Yeah.
Okay, so this is aorta. 97, 114, okay. Služeno pročitайте. And now I will measure the brachiocephalic trunk. Here is the brachiocephalic trunk. Absolutely the same. And now the left carotid. And this is the left carotid. No gradient at all. It means the chimneys are working. Okay, good, fantastic. Okay, we are going to remove the gel pigtails. They have two. Stop. Super. Малко към аортна клапа да виждаме. Чудесно, супер. Дръж тук безопасно. The aortic graft is with very good apposition. I had some resistance during removing the pigtail. It means it's over the landing zone on a perfect way.
What is that for a special action?
I don't know.
Now this is the other.
Sponsored lecture.
Okay, great. And we are ready
For Manta.
for Manta. Okay, let's start with the large bore. Мантата е тук. Валери, натискаме. Не искам да те приспиваме повече, защото завършвам.
Wait, now we have to say that we have Galadina. There will be no more presentation.
Okay.
Групаш.
So when he is finished, we go.
Три и половина.
We can ask, yes?
Групаш.
Somebody is not familiar with the closure devices and want to see that?
Okay, great. This is good
Because
question.
it's now dinner time,
Okay, so...
and so therefore that question,
Yeah,
when you agree, we will close the session.
yes, okay. This is the Manta because it's, let's say, newer. Let's show the Manta. So the locator is already within the artery. And this is the plug. This is the plug. So now with a click, the anchor is already inside. So, and we have measured in advance the level. So the level of opening the plug inside the artery. It's 5 centimeters in this case. So we now anchoring already because we have here a red marker. I'm waiting a little, the collagen of the upper anchor, outside anchor to activate. And finally, we make push-pull in order. Okay, and you can see now, probably you see,
Yes,
it's
you can see
20
that.
French,
So
20
it's-
French access,
Yes, it's not
20
not bleeding and it worked.
no bleeding.
Yeah.
So after assuring that it's no bleeding, we are removing the wire and we are cutting here
Yeah.
And that's
Okay,
it.
Ivo,
That's it.
thank you once
Okay.
again for the nice demonstration.
Thank you.
Thank you very much for sharing this very complex case with us. Both impressive and for me something quite new. I never saw this even in publication. So thank you once again. Our applauses.
Thank you for your patience.
Okay, waiting for you at the dinner. So thank you so much. And now
Yeah,
I guess
okay,
it's
yeah.
time to conclude this session.
Yeah.